Hi, everybody. Thanks so much for joining us today. My name is Nicole Lamberson. I was trained as a physician assistant, and I'm a member of the outreach team for the film Medicating Normal. And I host conversations like this one today. Our guest today is Dr. Helen Kales, Chair of Psychiatry at University of California, Davis. She is a fellowship-trained, board-certified geriatric psychiatrist. She has special clinical interest in the behavioral and psychological symptoms of dementia. She has led the psychiatric field in understanding the risks of using antipsychotic and other psychiatric medications in people with dementia. However, as she traveled the country presenting her research, she recognized it was not enough to simply tell providers, staff, family, and caregivers to avoid the use of these medications. Instead, it is imperative to help caregivers better understand, identify, and treat the underlying causes of behaviorological symptoms of dementia, rather than to the knee-jerk use of medication. Our solution is called the DICE approach, and it's now used worldwide by caregivers and memory care facilities to provide behavioral-based solutions. So welcome, Dr. Kales. Thanks so much for joining us.
Thank you so much for having me, Nicole.
Sure. Did I leave anything out that you want to add?
It sounds great. Yeah,
Okay.
It's enough.
Okay. So I guess first, what led you to be interested in dementia and specifically studying the effects of psychiatric medications on people with dementia?
So dementia is one of the most common things we would see as a geriatric psychiatrist. And oftentimes it's somebody who's coming in either because they notice something's different with their memory or their family does. And often there is a mix of the dementia or possible memory problems with psychological issues or depression or anxiety. And so as geriatric psychiatrists, we're trying to figure out what's what and sift that out. And so, as I went from fellowship to becoming an attending physician, dealing with dementia was part and parcel of my day-to-day work. And what I quickly realized was that for families and people with dementia, it's not really the memory symptoms that create a lot of the poor outcomes. It's a lot of the behavioral and psychological symptoms that lead to difficulties in quality of life. And what we now recognize is really important is living well with dementia. We're trying to get away from the idea that somebody is diagnosed with dementia and, you put them somewhere and they're never seen again, that people can really live a good quality of life. And so it really became a calling to think about how we manage those behavioral symptoms. And I just want to say for the audience that a lot of times nobody in the field really agrees on what to call behavioral symptoms. I think that in the past, people use terms like difficult behaviors or problem behaviors, and we're really trying to get away from that because first of all, we all have behavior. I have behavior, you have behavior. And so to me, talking about a change in behavior is really just like talking about a physical symptom it's something we're trying to measure. So I just want to make that clear from the outset.
Okay, great. So I'm going to ask you about some of those symptoms in a minute, but I recognized in myself that I didn't really, like when I started reading your work, I didn't know enough about dementia. So is Alzheimer's the only kind of dementia, or are there lots of kinds?
No, there are many, many kinds. So I often show a slide when I'm talking to audiences that shows an umbrella. Dementia is really the umbrella sort of syndrome, and encompassed under that umbrella are many different types or etiologies. So Alzheimer's would be the most common type in our country. In other countries, it may be vascular dementia, which is caused by, brain bleeds or brain infarcts. And there are many other types as well. There are types due to Parkinson's disease. You can have dementia due to certain viral diseases. So there are many different types. There's a type called diffuse Lewy body dementia. So under that umbrella are many different types, but for all intents and purposes, Alzheimer's disease is the most common type in our country.
Okay, great. And then let's talk about some of those symptoms. So what are the symptoms that are behavioral, I guess, that wind people up on psychiatric medication?
Sure. Well, before we get to that, I'll just say, to have people often joke as they get older, oh, I have old timers disease, or, oh, there's my memory. But having dementia is a very specific diagnosis that is made by a physician, whether it's a neurologist or a psychiatrist or a geriatrician. And that would be based on both the history, the physical lab work, often a CT or an MRI, and then neuropsychological testing. And so the cardinal things you're looking for is a sustained loss of short-term memory, but that's often accompanied by other, or should be accompanied by other symptoms, which could be word finding problems, could be problems with understanding how to do things in a stepwise fashion. It could be problems with what we call your executive functioning, which is sort of sequencing, organizing, and planning. It could be problems with physically being able to carry out certain functions. So it's a very specific thing, and it's not just, oh, I misplaced my keys, so I have dementia. So there's all of that. And then often accompanying dementia, or should I say almost universally accompanying any type of dementia, one study found 98% of people with dementia have behavioral changes. There could be changes like depression, so that's very common. Anxiety is another. Apathy, where somebody, has trouble even sort of initiating the interest to do anything. They, as we would say, they're apathetic, or they lack sort of the interest or motivation. We can see things like agitation, where it might be verbal, or aggression. Somebody could be striking out, sexually inappropriate behavior. Interestingly, though, when caregivers are asked about problematic behavior, they often cite things that you or I might not think of. So asking the same question over and over again, that the person simply forgets that they asked it, but they say, when's my doctor's appointment? And the caregiver answers. And then, half an hour later, when's my doctor's appointment? And this goes on throughout the whole day. And, for caregivers, this can just really wear on the soul,
Yeah.
And there could be other behaviors like following the caregiver around the house or trying to exit. So there's really anything you can kind of think of can occur. And I think what often happens with dementia is people receive a diagnosis, and many caregivers will tell me, nobody really told me that I knew about the memory issues, but I never realized that mom might hallucinate or become aggressive. So I think that's what's really important to know, is that these are super common.
Yeah. Okay. That helps a lot. And just putting it all into context and understanding why you needed to develop this DICE approach to begin with. So, do psychiatric medications work for dementia? And I guess then you have to define what work means.
Right.
Yeah.
Right.
Mhm.
Yeah. So if we could back up to the 1990s, that's when a lot of the drug companies were seeking indications for their medications for dementia. So the FDA, approved certain medications for certain conditions. And all right now, there is really no psychiatric drugs in this country that are approved for use in dementia. So all use is really off-label for the behavioral symptoms of dementia. But in the 90s, they were really seeking, well, we're going to use this or that for psychosis or agitation. And so there were a lot of drug trials that were funded. And what happened was there was a large trial called CADI, AD, that was looking at the efficacy of these antipsychotic drugs in dementia. And the big upshot was, after a very large trial, they found that they were not really effective as defined by their endpoints. And so that really began, the question of what are we doing? How are we using these drugs? And at the same time, we and other groups started looking at the side effect profiles of these drugs in older individuals. There had been reports of higher risk of stroke in people with dementia and higher risk of metabolic syndrome, which includes diabetes. And there was then a study in the New England Journal of Medicine that found that they were associated with a higher risk of mortality. And we and other groups subsequently confirmed that. That led to the FDA putting out a black box warning, which is the sort of highest level of caution for medications on these agents. So getting back to your question, I think of it all as a risk benefit for any patient, whether they have dementia or not. I think when we use medications, we think of risk benefit. The best evidence we have for medications and dementia is actually for antipsychotics, which have the highest risk. There is some evidence that for certain agents, Risperdal is one of them, that there has been some trial evidence that they are effective for some people. And we believe they're most effective for people that are truly psychotic. So if somebody has a psychosis and let's say they believe their food is being poisoned and they're not eating, and there's a really big inherent risk there, that would be the risk benefit calculation you want to do for using an antipsychotic. But so a lot of other medications are used. Antidepressants are used very, very widely. The evidence is not that great that they work in people with dementia. We still use them because, again, risk benefit and looking at certain profiles of depression, we might choose to use one. But what we really started to worry about was not that there shouldn't be any use of psychotropics in dementia, but the knee-jerk use, meaning this person is having some symptom, call a doctor without any assessment, without any, history, without any physical, call in the antipsychotic, call in the sedating agent, and not really look at what's underlying the behavior. And in parallel, what's very interesting is, in what I would call the more psychology, social work, nursing aspects of this field, they were looking and creating models of behavior as unmet needs. And so I became very interested in that, along with my collaborator and colleague, Laura Gitlin, who'd been doing work in this field. She's actually an applied sociologist, but we began to team up because it was sort of like, why do we have this dichotomized medications on one hand by this field and unmet needs by this field? And I think looking at these behaviors in totality, thinking about unmet needs, and also thinking about people with dementia as trying to communicate something with behavior. We all communicate with our behavior, right? And so if somebody, especially as dementia progresses, has more trouble speaking or has more trouble articulating what's going on, they may express that through behavior. And by medicating somebody without assessing it, we're missing the chance to really, make an intervention that would actually be more effective, patient-centered, and improve quality of life. So that's what really spurred us on.
Okay, that makes a lot of sense. You mentioned the antipsychotics and antidepressants, but what about benzodiazepines? I mean, I know they're used for sedation quite a bit, but they really are indicated mostly for the short term. So are they also being used kind of long term?
They're being used long term, yes. And we, so in the DICE approach, which we can talk about more later, we basically talk about 3 indications for medications. We do not prohibit the use of medications. There's 3 indications. There's a severe depression that could cause risk to the person with dementia. So maybe they're suicidal, or maybe they're not eating. So we would want to use an antidepressant in that case. Secondly, there is psychosis with risk. So somebody has a psychotic symptom, maybe they're delusional, maybe they're hallucinating, and it's putting themselves or a loved one or somebody else at risk. And then thirdly, aggression with risk. So it's in the aggression with risk that we would often see, for example, in an emergency department or somewhere else, the use of a benzodiazepine. In a very short term, like one time I'm talking about use, that may be okay. But what happens, unfortunately, is people often end up on these agents in the long term. And in the long term, and I'm talking about even a week or more, the problem with that use is it actually really is antithetical to what we're trying to do. So benzodiazepines worsen memory, as you probably know. And so giving that to somebody with a poor memory is not a great idea. It actually affects the part of the brain called the cerebellum, which helps us to walk and balance. And so people who are taking benzodiazepines are more at risk to fall, which again, a fall can cause a cascade of badness in somebody who's older and, end up in a nursing home or with a hip fracture. The other thing that's really interesting about benzodiazepines in people with dementia is it can cause what's called paradoxical disinhibition. So as opposed to calming the person down, for whatever reason, it affects the brain circuitry differently and they become more agitated. And so we really caution, when I give lectures, I actually put up a little skull and crossbones sign for benzodiazepines. I don't like to see anybody put on them who's older. Because of these side effects, I've actually seen people who don't have dementia develop what looks like dementia because they're on benzodiazepines. So it's a real risk. And when somebody does have dementia, you're really kind of shooting yourself in the foot. So I would rather have a person use an antipsychotic short term at a low dose than a benzodiazepine. And that's the other thing I haven't even mentioned is that the longer somebody's on a benzodiazepine, the more they get used to it and the more they're habituated to it. And so that becomes a problem as well.
Yeah. Okay, great. Yeah, you mentioned sometimes people taking psychiatric drugs or benzodiazepines can present like they have dementia. I mean, is that ever misdiagnosed? Like someone's on medication and they are diagnosed as having dementia, but then they are deprescribed and they don't actually have it?
Yes,
Wow.
I've seen it happen both with benzodiazepines as well as what are known as anticholinergic drugs. So anticholinergic, basically acetylcholine is what helps our memory system. And so when you're taking an anticholinergic drug, and that could be anything from Tylenol PM to Benadryl to it's in a lot of different cold preparations and allergy preparations, a lot of the over-the-counter sleeping medications. So I've seen people taking a lot of that who look like they have memory problems because they sort of think, well, this is over the counter, I'll take it for sleep or for allergies or for whatever. And it ends up really impacting their memory. I've even seen delirium with anticholinergic drugs. So it depends on the person and their sensitivity, but we should be really careful about what medications we take in older age because even if something's over the counter or from a health food store, it could have those side effects.
And elderly people, just by, way of being elderly, they don't metabolize medications as effectively as younger people, correct?
That's correct. So, as you get older, your metabolism changes and it slows down, and the liver metabolizes things more slowly. The kidney may process things more slowly, than it used to. And in addition to that, older people are just taking more medications. So there's kind of polypharmacy on board, and, somebody might be taking 10 different medications and those things could interact. And so it kind of introduces a perfect storm where side effects can occur. And so it's really important to take a look at medications in their totality. And, that can be difficult because older people see a lot of different doctors. And so it's really important to have sort of one primary doctor who can look at all the medications and kind of say, like, wait a minute, I'm a little concerned about this one, or this could interact with that one. And just as you get older, that's something we all need to look at.
Okay. So this might be kind of a loaded question because I know that things are complicated, but if the medications are so risky, especially in older people and in people with dementia? I mean, I know we have the, is it called the Beers list or the,
Beers
uh,
criteria.
yeah, where it says, benzodiazepines should very rarely be given to older people. But then if you look at the statistics, like they're the highest prescribed group,
Right.
dementia taken out of the picture, just elderly people in general. So why is it such prevalent practice, do you think, that psychiatric medications are just quickly the go-to for dementia patients?
So I think, and in older patients in general, I think it's easy to do. So if you think about, and this is definitely no slight meant to my primary care colleagues, because they do a lot with a little bit of time. My brother's a primary care physician, and I respect what he does intensely. And so they're trying to manage, potentially 10 or 15 different medical problems and psychiatric issues, all in a very, it has to do with how our healthcare system is laid out, right?
Yeah.
So, you go into the medical chart, it's fairly easy to write a prescription, right? And patients actually really like those agents. So they experience them as pleasant. I've rarely had somebody say to me, I've got to come off this benzodiazepine. I mean, people experience them as pleasant. They take away your anxiety. And so, it's not something that the patient is going to present as problematic. But I think we have to look at the longer term kind of implications for the use of those agents. And one of my colleagues at Michigan, Donovan Moss, is actually working on a project to help physicians deprescribe and actually not prescribe these medications and think about alternatives. And that just takes a lot of work. There's a lot of effort going into that to really educate people about the downstream implications of, because once you get started on a benzodiazepine, it's much, much harder to come off. So the idea of never going on one, trying alternatives, trying behavioral approaches to sleeping problems, for example, that's much better than starting somebody on a benzodiazepine right off the bat.
Yeah. Okay. That makes a lot of sense. So when someone is in a nursing facility, with dementia, their family puts them in there because they need help caring for the person. If you have dementia, what kind of informed consent is being given to dementia patients, or does it go mostly through the family?
It sort of depends on the stage of dementia. So, while the patient is able to give informed consent, they'll often do that. But once the patient reaches a certain point in dementia where they can no longer do that, then the family necessarily becomes the proxy for that.
Okay.
And so, often the conversation for me might be with a family to talk about, here are the risks of a certain agent and here are the benefits. And, what would you like to see happening? And I think that's a good conversation to have with families in terms of, what's the trajectory? What are they doing? What are they worried about? And, most patients with dementia, you mentioned the nursing home, are actually in the community.
Mhm.
So the goal for a lot of us is to keep patients at home if they're doing, reasonably well there, because nursing homes, take them away from their families, and then that becomes something that the families have to, come visit them. And so that becomes sort of an added burden. And so it sort of depends on the family. For some people, that's something that's really beneficial. But in other cases, staying at home and being in the home environment where they're known and their likes and dislikes are known and their activities are known is the goal. And so we, with the DICE approach, we try to reach caregivers. So that's one thing that we've done is, as opposed to centering the approach on physicians, we made the decision when we created it that this would be created, first of all, for everybody, because physicians generally need to be trained in behavioral approaches as well, but that we would be training caregivers, because those are the people. There's more than 5 million people with dementia in the country, and there's 15 million family caregivers, and largely they're navigating all of this by themselves. And so we wanted to create an approach that would really boost that person, would empower that person to be able to impact behavior where they're seeing it and to have a voice in the approach. And so that's why we centered it on caregivers.
Okay, great. Yeah, so let's, I guess, move into the DICE approach. You developed it with colleagues, and I guess can you sort of give a summary of what it is and how you teach caregivers to become behavioral detectives?
Yeah, absolutely. So we developed this starting about 10 years ago when we realized that we were at a meeting, Dr. Gitlin and I giving a symposium, and it was all geriatric psychiatrists in the audience. So, right, experts, right? And we asked people how routinely they use behavioral approaches in their own patients. And out of a crowd of maybe 100 or 200, we only got a couple hands. And so we were really struck by that these are people who, know how to do an assessment, but really hadn't incorporated this into their day-to-day practice. And so we decided to hold a one-day, all-day kind of brainstorming session with people from across the country. And we deliberately included people who were non-physicians. So nurse experts, social work experts, psychologists. We had a pharmacist, we had a geriatrician. And that group talked all day about what would be an approach that we could, what would be the elements that we would start to put into that approach. And so that day, the kind of structure of DICE was born. And across the next few years, we created the scaffolding for it. And so what it is, it's not, as someone once said to me, it's not rocket science, it's packaging. And that's really true. Mm-hmm. The acronym is DICE. So it stands for describe, investigate, create, and evaluate. And so describe is the really key step, because one of the things we find in clinical settings or even at home with caregivers is that often behaviors aren't described fully. So somebody will say, grandma's agitated. But if you say that to me, I have no idea what's going on. Grandma could be hitting you. Grandma could be pacing back and forth. She could be, walking around the house. She could be rocking on her rocking chair fast. I just don't know what she's doing. So what we teach caregivers in that step is to really unpack it for us. And in our trainings, what we do is we use the example of the movie The Wizard of Oz, and we say, if you were trying to tell somebody that had somehow been, isolated in a cave and had never seen this movie, what happens at the end of the movie, what would you say? Mm-hmm. And so saying that, the witch dies, yeah, that is what happens at the end. But we really want to know the who, when, why, what, where. And so we want to know that Dorothy was in the castle. It's at the end of the movie. There's flying monkeys. She's with all of her friends, and the witch goes to throw a pail of water on the, the witch lights the scarecrow on fire. Dorothy throws a pail of water. The witch then melts into the floor. So now your friend really can play back to you, what happened. And just like that, we want caregivers to be able to fully tell us, grandma was being led to the bath. It was the afternoon. It was kind of cold in the bathroom and kind of dark. I had the water turned on. I was in a hurry because I had to get her to an appointment. So I kind of pulled on her arm. She then began to hit me and yell at me to let her go. So then you really see, like, we have a fuller description and an understanding of what was happening. And so that's what we really want people to be able to flesh out, because from that, we can then go to the next step, which is being a detective, looking at the symptoms and saying, what could underlie these symptoms? And we always want to think about common things are common. So, has grandma had a medication change recently? Has she been in pain? And when you pulled her arm, did that trigger something off in her? Does she have arthritis and it's untreated? Are there issues going on with the caregiver? So we always train the caregivers to think about a triangle, which is the person living with dementia, the caregiver, and the environment. So the caregiver is the actor that we need to think about in this play, right? Mm-hmm. That the caregiver might not be educated in dementia and might think grandma can do more than she can at this point, may think she can, may fire off a couple requests to grandma, but she can't process them. Or, one thing I often hear from caregivers is grandma's doing this on purpose. And we have to sort of reorient people to the idea that, in dementia, people aren't doing things on purpose to make you upset. It may seem like that, but it's really not something they're doing consciously to try to bother you, but more because their brain isn't working very well.
Yeah.
And reframing that can help people, because when people get angry at somebody, then all bets are off, because behaviors get mirrored in the person with dementia, and it's a dyadic intervention. So we really want the caregiver to be thinking about, what are they bringing, to the interaction? Were they hurried? Were they upset? Were they, and this isn't victim blaming at all. Caregivers have like one of the toughest jobs in the world, but just thinking about, what tone were you using? Were you being confrontational? What was going on? And then lastly, the environment. I mentioned that the bathroom was cold. Could we warm it up? It was dark. Could we have prepped grandma for this activity a little better? Could there be things in the environment that might be inviting, like bubbles in the bathtub, or some kind of chocolate treat at the end or something like that? And so that necessarily leads to the next step, which is where we create a treatment plan. So we're looking at, what are the things that we can act on from what we learned in the investigate step to really intervene and help. So this might be, prepping grandma with some Tylenol if she has some pain, so that getting into the bathtub is easier. It might be working on the caregiver's approach to kind of get grandma ready for the bath. It might be making the environment, more inviting. And then the last step is evaluate. We want to make sure that whatever we did, we kind of evaluate how it worked. If it worked, that's great. If it didn't work, we want to maybe tweak it, or we want to approach it in a different way. So it's pretty simple. But the complexity is in that it's not a cookie cutter. So it's tailored to everybody who, is a person living with dementia or a caregiver, and to their particular environment. And you asked earlier how we train people. We train them in a number of ways. So we have a manual that's available on Amazon. So people, we've sold over, I think, 600. So I think, it's available at a very nominal cost, and they can purchase that and kind of read up on the approach themselves. We have a training website where people can go 24/7, and it's basically divided into modules, learning modules that people can take. And then at the end, they can test themselves with some simulations of cases. And then we also have trainings that we've done in person throughout the state of Michigan, Wisconsin, and then here in California. And we're also doing some hybrid approaches where we do a combination of the website and in-person training. So, it's disseminating, and that's exciting. But we clearly don't have big pharma behind us. So it's not being disseminated as quickly as maybe we'd like it to be. But yeah, I was just saying that the DICE approach is meant to be shared. So we have worksheets that people use when they're doing the approach, that they can kind of write down the strategies they're using. They can share those with family members, and they can also share those with primary care physicians, because in some cases what they uncover is, oh, I think that the behavior may be due to an underlying medical issue that hasn't been fully worked up yet, like a urinary tract infection. We've had a couple cases like that. And so then linkage with the PCP is very useful, because basically treating the behavior is treating the underlying medical condition. And so all of this goes to say that a lot of times what we uncover through the approach is that, fairly simple behavioral approaches can be used an alternative to medication through, the caregiver understanding what's going on with the person and the environment and themselves, and kind of brainstorming and thinking about, they're the ones that know the patient or the person living with dementia the best, and can often come up with the best solutions for what's going on.
Okay. But to be clear, anybody who has contact with or who's working with a dementia patient can benefit from the DICE approach and they can
Absolutely.
apply it.
Yes, we definitely have, assisted living places using it. We have people who have learned it and then they've put their loved one at a nursing home or assisted living. They continue to use the approach through that. So yeah, it's definitely meant to be used across a wide variety of settings. We've also recently talked with people in the emergency department at UCSF about using the approach in the emergency department and trying to use it proactively so that ahead of an older person getting scared, upset, possibly trying to wander out of the ED and then getting an IM injection of an antipsychotic, that we kind of look at what's going on with them ahead of that and say, okay, they're getting upset. Let's start to reorient them. Can we bring a family member in to give them some added sense of safety? What can we do to help them make safer so that we don't escalate to that point? So it really can be used in a wide variety of settings.
Okay, great. It sounds like you said so simple when you break it down like that, but I'm sure when you're the caregiver and there's these behaviors and stuff, it takes some time probably to
It
really.
takes some time and it's sort of a shift of thinking. And what we like to what people get really excited by, when we do our one-day trainings, the end session is a brainstorming session where we have people actually bring in their real world problems, and we kind of go through the approach and elicit kind of crowdsource ideas.
Mhm.
And people always love that because it's so empowering, and people begin to say like, oh, I get this. I get that I have the ability to do something about this. And I hadn't really thought about it in that way because we're sort of trained to think about, oh, medical issue, must call doctor, when in
Mhm.
fact, some of the best solutions can be elicited, from the caregiver themselves. It's just a matter of kind of allowing themselves the luxury of kind of thinking about it. And I think one of the things that happens in caregiving is people get so overloaded. So
Mhm.
another thing that we teach caregivers in the trainings is that it's really, really important to take care of themselves, because often what happens in dementia is that so much time, energy, and wavelength goes into being selfless, being a caregiver, helping that person, that they begin to ignore their own needs. And
Mhm.
then that can backfire. So I always tell people, don't go down with the ship. If you go down, the person with dementia is not going to do very well. So you need to take time for yourself, whether that's respite, getting somebody to come in, having another family member sort of rotate with you, just things that you can do for yourself on a daily basis. And that actually impacts the person with dementia's behavior. We did one study where we found that one of the biggest factors for a caregiver bringing somebody into the emergency room for behavior was not the behavior itself, it was the amount of stress the caregiver had. So the more the caregiver can de-stress and get some help, the better off the person with dementia will be. It's really an interactive triangle, like I talked about.
Yeah, which makes me think too that, just like all the other problems we have here in the United States that and worldwide really, although some countries handle things differently with resources and that kind of thing. Just considering, I have friends who are older than me who are caring for parents and stuff with dementia. And I say all the time, like, what if you didn't have money, or, you didn't have other family members to lean on and that kind of thing? I can imagine it would be so much harder if it's just you and you're working with very limited resources to care for somebody.
Yeah, I mean, it was really interesting. A number of years ago, I was on sabbatical and I went to Japan to look at how they handle old age and dementia. And it's a completely different paradigm. I mean, they really look at it as a society. And at the time, one of the things that they were doing that was so, to me, clever was they were training their bus drivers about dementia and how to handle people that had dementia, because they found that some of the people with dementia would get on buses and forget where to get off and then, end up somewhere 100 miles away. So they've looked at it as a societal need that everybody, would contribute to that. And I do think we're starting to do that with dementia, but it's still largely, as one of my colleagues put it, like islands with no bridges between them. And I think that if, we look at the numbers and where our, aging society is going, we really need to think about this as a society. And I am really encouraged that programs like the all-inclusive programs for the elderly, the PACE programs, are starting to think about this. We have one in Michigan where they have trained the entire operation on DICE, including their shuttle drivers, their food workers, everybody, because what they recognize is that everybody is going to be dealing with the person, and they wanted to have one consistent approach. So I do think your point is extraordinarily well taken.
Yeah. Okay. So I guess you guys have got a grant for this method and another grant for the online platform. You're doing a study of the DICE method. So is that still ongoing?
Yeah. So and I can send you the link for the online platform that maybe you can put up on Facebook, because we are seeking people.
Sure. Okay.
So the new grant is the DICE approach in primary care, where we're going to be training nurses who are basically care managers in our primary care settings on the DICE approach. And then they will work with the caregivers to amplify the approach with people living with dementia. So they'll be doing that in primary care. And what we hope to show is that with very little resources, just basically the training, that we can reduce medication use and ED visits and sort of inpatient, care that we hope not to get to, because we want to manage people outpatient. So that'll be kicking off this fall. The trial that's ongoing is sort of a souped up version of DICE. It's called the We Care Advisor, and it is an app that is available on the phone. And we're looking for 300 caregivers. And we've already recruited, I believe, about 75. And we're really happy because we're doing a national recruitment. And I think we've recruited from almost every state so far. So what's really cool about the app is it has the DICE approach, and it's basically bypassing the whole need for training. So the approach is in the app, and across 5 to 6 screens, the caregiver inputs the behavior, the circumstance, some things about them that they're dealing with, and then comes up a prescription for what strategies to use. And the secret sauce in that is we've put about more than 1,000 strategies into an algorithm that, depending on what the caregiver tells us across those 5 to 6 screens, the app will pull those out specifically for them. In addition to that, we have in there something called the Caregiver Survival Guide, which is basically meant to be a compendium of information about dementia that they can access anytime they want. And then they also get daily motivational messages through the app. And we did an earlier trial, a smaller trial, where we found that that was one of the favorite things of caregivers, because it's such a hard job. And they said, being told I'm doing a good job actually, had an impact on me. And we were able to show in that small trial that the app had a significant effect on the caregivers, increasing their ability to care for the person in the home and decreasing their amount of burden. So we're hoping to show that in this larger trial. And I can send you the link for the recruiting website later.
Yeah, do. And for people who are watching this on YouTube, we'll put it in the description and they can go and find it there. Yeah, sure.
Yeah, we're really excited about it. I think it's really, people that use it say, I wish I had this before. It's very fulfilling for them to use.
Yeah. So I guess I had another question about psychiatric medications in people with dementia. I mean, I know that's the focus of your work, but I wonder if you're familiar with what the science says, or do we know enough about can psychiatric medications cause dementia in people later in life? Are they a risk factor for developing dementia?
So I don't think we know that at this point. There have been a number of really big observational studies that show that anticholinergic drugs, maybe the use in mid to later life, could be associated with dementia. But again, association isn't causality, so we don't really know if that is a direct effect or if it has to do with something else. I think, it leads us to be concerned. I think, there also may have been some studies showing some links with the benzodiazepines, but again, is that association or is it causality? We don't really know enough. We are, I was part of a Lancet International panel, and I can also send you the link. We published 2 papers on things that are associated with the later development of dementia that are potentially modifiable. And I think that, the field has long been focused on sort of finding the cure. And ever since I was in training, I was told, oh, it's just around the corner. It's just around the corner. And I think the reality of that is we're not just around the corner from a cure. And even if we were, it would only probably be for a very specific type of dementia, and not for all of the dementias that occur. And so what our panel in the Lancet chose to focus on are things that are, again, potentially modifiable that seem to lead to dementia. And one of the biggest in midlife is hearing loss. And that is modifiable. So there are a lot of studies now looking at the impact of, early intervention hearing aids for people in midlife. And I think that's really important. I have a father who did not want to use hearing aids in later life. And I was able to tell him, Dad, there is a risk of dementia with not, so if you're embarrassed, maybe get over it because, and we don't know if that's a direct brain effect or is that like a social effect where somebody, because we know that social isolation and loneliness are also associated with dementia. So the more you have hearing loss, the more you're sort of pulled out of day-to-day interactions. So I think looking at those risk factors, which also include things like hypertension, pollution in developing countries, those are really important to think about, as well as secondary education. For countries that are, burgeoning, is to think about the impact that education, we think that education gives people a buffer or reserve such that they're able to continue to function, even though they may have some impact of dementia, they've got that cognitive reserve that may help them. So I think just like, we reduced the number of motor accident deaths with seatbelts in the 60s, starting to look at these modifiable risk factors for dementia is really where we should be focusing. And there's a number of trials nationally and internationally looking at those now. And I'm really looking forward to seeing the results on what impact that has.
Yeah, that's hugely important. I mean, as a society, we're so terrible about just wanting to put Band-Aids on things, but really where the information is at is like, how do we avoid
getting there in the first place?
Yeah,
right.
exactly.
Right.
So.
And we've done that with things like cardiovascular disease. And so I think it's very doable. And I think that if you, in my older patients, they're very motivated to avoid dementia. So thinking about things they themselves can do. And I always tell people, if you're older, for me, it's the triad of cognitive activity, physical activity, and socialization. So if you can find something, I had patients that took up square dancing. If you can find out something that kind of tweaks your brain, gets you active, gets you engaged, that is the best you can do to, in some cases, to avoid memory issues. And it's certainly not going to hurt you. And it's probably going to help you in a lot of ways too.
Yeah. Okay, great. That's a good tip. So we have a question from the audience before we close. Somebody wants to know, a lot of our viewers are really interested in psychiatric medication because they were either harmed by them or know somebody that was harmed by them. So I asked you before about people in nursing facilities with dementia and informed consent, but I guess it's sort of a two-pronged question. Are there families and people with dementia who are, surviving and thriving with dementia who absolutely just refuse psychiatric medications altogether? And if you are someone who is sort of looking down the line at like, if I get dementia, I don't want psychiatric medications at all. Are there people who are like writing advanced directives or, saying, I don't want to go this path?
What a great question. I think the first part of it is largely dependent on the facility you end up in. Sadly, there can be a lot of pressure sometimes for families to put patients on psychiatric medications in these facilities, to the extent of, I've even heard families say, we're worried we're going to lose our placement if mom isn't put on this or that or the other. And so often that is a job for me as a physician and an advocate to call that facility and work with them and try to say, like, what are we really trying to do here? And can we do something different? And so I think in many cases, it's finding the right setting and facility who will work with you on non-pharmacologic approaches. I think the second, I don't know of anybody who's working on advanced directives like that, but that is absolutely fascinating to me. And I think that as, we start to see more advocates who have early dementia, I had the privilege of being on a panel with somebody a couple of years ago who had early dementia and, is an advocate for living well with dementia. And I think we'll probably see more of that. I think that's a very, very thought-provoking and interesting question.
Yeah. Okay, great. So I guess final question. I mean, you've come up with the DICE approach, so you must have some hope that we as a society can move away, from these dangerous practices. But do you think really we're mostly still going to be stuck with this quick fix mentality, or can we get there in the end?
So this is going to seem a little far afield, but I'm really inspired by somebody named Ignacio Ponseti, who is a pioneer in the treatment of non-surgical treatment of club foot. My son was born with a club foot, and Dr. Ponseti, it took him 50 years, but he completely changed the paradigm from one of basically cutting all the, muscles and tendons in a baby's foot to one where we serial cast people, and it's completely, non-surgical, which is what my son had. And I'm inspired by that. And I remember talking to Dr. Ponseti, who's about 92, when I saw him with my son, and he said, they kicked me out of several hospitals in Baltimore because they said I was, doing the wrong thing. And so I hope to see it in my lifetime. I hope it doesn't take 50 years. Mm-hmm. But sadly, we haven't really moved the needle. There's still about 70% of people with dementia, both pre and post black box warnings, who are medicated with a variety of psychiatric medications. What I think it's going to take is governmental and policy interventions at the level of, the Center for, Medicaid and Medicare, really saying we need to implement these approaches. Currently, the approach is, okay, what's the percentage of people on antipsychotics in your nursing home? And that's sort of the gold standard. That's not enough, because physicians will go around that. They'll prescribe a different drug. They'll prescribe a different sedating agent. And so and they don't have anything to replace it with. We need to give them the tools so that they're trained and have the approaches to deal with these conditions, where they're living and working, because they're very difficult and they do create difficult outcomes. So we need to do that, I think, at a very high level, because starting at the grassroots helps, but we also need the societal and policy piece, I believe.
Yeah. Okay. Well, thank you so much for joining us.
Thank you. You had great questions. I really enjoyed it, and I'll be happy to send you a few links.
Yeah, please do. I think we put some links to the DICE approach. It's diceapproach.com in the comments, and we'll put them on YouTube as well. And then you send us the links that we discussed for sure. So there are places where you can find or follow you, or that you want anyone to know about before we close.
Just what I'll send you. Yeah, that's
okay.
Great. I'm not a Twitterer, so.
Okay. Yeah. Some people just, stay away from social
Low
media.
Tech.
Yeah. Maybe go do something brain stimulating instead.
Exactly.
Right?
That would be the best thing.
Yeah.
Thank you so much, Nicole. Take care.
Yeah, sure. All right.
Bye-bye.
Take care. Bye. So thanks everybody for joining us for this live discussion. If you haven't seen Medicating Normal, please check out our website at medicatingnormal.com/watch for the many ways you can watch the film. You can buy the film on DVD if you're in the United States and Puerto Rico. And the film is available now for download on Vimeo and Apple TV. As always, check the events tab on our Facebook page for more upcoming interviews like this one. And lastly, if you'd like to support our outreach efforts to bring the film and more conversations like these to communities worldwide, make a donation at medicatingnormal.com/donate. So thanks again to Dr. Kales for joining us today. Thanks everybody for tuning in, and we will see you next time. Bye, everybody.